Last lecture talking about our structural classification of joints. You'll notice that for each of our structural classification, I also give you a functional description. So let's go through these again to make sure we realize what the structure is that's going to be holding these joints together. In a fibrous joint, it's going to be typically fibrous irregular connective tissue. We talked about it last lecture or the lecture before, how it's a stronger connective tissue than dense regular connective tissue. An example of a fibrous joint was a suture. Cartilaginous joint is where cartilage holds the two bones together. An example of that was your sternum and your ribs, or the pubic symphysis that is located between your two pubic bones. The third structural classification is the synovial joint. This joint is quite complex, and we'll talk about it later in today's lecture. These are freely moving joints where the fibrous is immovable, the cartilaginous is slightly movable. Now when we talk about our functional classifications, they've got different names. We have synarthroses, which are immovable joints. And what makes this a little bit more confusing for you is we only have a certain number of joints that are immovable. So we're going to double back and say, yeah, our example of a synarthrosis is the sutures between the bones of your skull, which also happen to be fibrous joints by structural classification. Amphiarthrosis are slightly movable joints, and again, our example for that is going to be the joint between the sternum and the ribs and the pubic symphysis. A diarthrosis are freely moving joints, your knee, your hip, your ankle, your shoulder, those synovial joints that we've talked about before. Now, let's talk about our synovial joint a little bit. As we said, they're rather complex. The two articulating bones are separated by a fluid-filled cavity. Okay, we talked about the synovial membrane when we talked about the membranes for exam number 1. They are, by functional classification, a diarthrosis. They are freely moving. You will notice if you look carefully that the green line in our joint cavity is the synovial membrane. That's going to produce that synovial fluid, that viscous fluid that we talked about. General structure, there's going to be articular cartilage. This typically is made of hyaline cartilage. This prevents the bones from grinding and rubbing against each other. In this diagram, it's the blue colored portion. The joint cavity or the synovial cavity, that's going to be the space between the bones and surrounding the bones that will be fluid filled. The articular capsule, that includes the connective tissue that surrounds the two bones and helps keep them in place. It's made up of the fibrous capsule and the synovial membrane. It acts as a bit of support to keep the bones in line, one stacked on top of the other. The synovial fluid is the fluid that will fill our joint cavity or our synovial cavity. It's made of hyaluronic acid, which we talked about, that thick viscous fluid that's going to be produced by the synovial membrane. And sometimes, most times, it's a little too thick, so we're going to thin it with a filtrate of blood plasma. Blood plasma is the liquid part of the blood. Blood plasma is the part of the blood that we've removed red and white blood cells from. And we're going to run it through a filter. So basically what's left entering your joint cavity is water. Right? So that's what we mean by the filtrate of a blood plasma. And it helps to thin the hyaluronic acid. We don't want it too thick. We don't want it too thin. We want it just right. And the combination of hyaluronic acid and the filtrate allows us to achieve that correct viscosity that we're looking for. We also have reinforcing ligaments. For example, the medial collateral ligament and the lateral collateral ligament. Again, most injuries that we hear about in sports occur at the joints, especially the synovial joints. Medial collateral ligament, lateral collateral ligament are two ligaments that we often hear about being injured in a sports-related injury. These work to reinforce the two bones stacked one on top of the other. Because our synovial joints are really complex and there's a lot of movement going on there, we're going to need some supporting cast members, and that's where the bursa and the tendon sheaths come in. As we say, they're going to be closely associated with synovial joints. The bursa specifically are bags of lubricant to reduce friction during joint activity. They're kind of a little shim that we put in to prevent bones from grinding on each other in an area where they get a lot of use or repetitive motion. The tendon sheath acts similarly. Excuse me. A tendon is made of strands of fibrous connective tissue. And if you think about a rope moving along a wooden dock, eventually, right, that motion going back and forth is going to cut the fibers, and eventually your boat is going to no longer be tied to the dock, it's going to be in the middle of the lake. If you envision your tendon as that fibrous rope being dragged across bone over years and years, you're going to end up breaking those fibers. We don't want that to happen, so we wrap a tendon sheath around it to protect our fibers from getting damaged by wearing and tearing on the bone. Next, we'll talk about some joint ailments. First is a sprain. We talk about sprains all the time. What, in fact, is a sprain? Those reinforcing ligaments that we just talked about are stretched or torn. Here's the problem. Those reinforcing ligaments, their job is to keep the bones in line, to keep them in the correct position. If they're stretched or torn, there's nothing to hold the bones in place, so bones are kind of flopping and flipping around each other and grinding on each other, which can be quite problematic. Sprains, if you've ever had one, you know that they are very slow in healing. Oftentimes you hear, oh, gosh, that's a really bad sprain. You would have been better off if you broke it. That's because the reinforcing ligaments are poorly vascularized. There's not a lot of blood supply to them. And you think, well, so what? Big deal. Well, it's a huge deal because when you have damaged tissue, you need to get supplies in to make those repairs, and you need to get some waste product out to clear out the area. The job of that falls on the blood vessels, and if you don't have a lot of blood vessels servicing the ligaments, then you're going to have kind of a logjam of getting materials in and waste out so that the healing process can occur. Cartilage injuries, and again, due to poor vascularization, it can't repair itself. They're not getting the supplies in, you're not getting rid of the waste. Typically, cartilaginous injuries, don't heal well, if at all. The most common injury is the meniscus of the knee. I've got a diagram coming up. The meniscus acts as a shim, a stabilizer, because although the condyles of the femur sit really kind of nice on top of the tibia, it's a little wobbly in there. So the meniscus helps to stabilize that. When that is damaged, it destabilizes the knee. A dislocation is exactly what it sounds like. Bones are forced out of the normal position. They're no longer in alignment as they're supposed to. Typically, a dislocation is accompanied by sprains and inflammation, which makes sense. If the bones are not lined up, if the bones are forced out of position as they're supposed to, you're going to be stretching or tearing those reinforcing ligaments whose job it is to keep them in line. Bursitis is exactly what the name is telling us. It's an inflammation of the bursa, typically from excess friction and stress on that joint. An example of bursitis is tennis elbow. Oftentimes it's a repetitive motion injury. This is a photograph of an arthroscopic surgery. That rough piece is a torn meniscus. The cartilage has been damaged. The best way to fix that is to go in with a teeny tiny pair of scissors and cut away the damaged tissue to prevent that grinding and pain that is associated with a torn meniscus. Next is arthritis. Arthritis is an umbrella term. There are probably 50 different types of arthritis or conditions that would fall under arthritis. We're going to talk about a few. First is osteoid arthritis. If you look at that articulating cartilage, you see that it's all messed up. It's roughened, it's wearing down in places, it's rough in other places. That's what happens during osteoid arthritis. It is a degenerative condition, which means it gets worse with time. We refer to it as wear and tear arthritis. Again, a typical college-age student isn't going to really suffer from osteoid arthritis, but someone who is older, who have used their joints for many, many, many years, will probably experience some degree of osteoid arthritis. As we said, it affects the articulating cartilage. It gets broken down. It's very slow, irreversible, rarely crippling. I would debate the fact that it's rarely crippling. My mother suffers from osteoid arthritis in virtually every joint in her body and has had 2 knee replacements, a hip replacement, probably needs the other hip replaced, and she really is pretty crippled up. She's dependent on a walker, and any movement is very, very painful because of the degeneration of the articulating cartilage. Next, we have rheumatoid arthritis. This is a chronic inflammatory disorder. It affects the connective tissue of the skin, the lungs, but mainly the joints. It destroys the small joints of the fingers and toes. Causes, well, there are several. It can be a transient infection, which triggers an autoimmune response. It could be a genetic component of an autoimmune disease. You could simply have a genetic predisposition that it's in your genes to show this trait of rheumatoid arthritis. Treatment, we start off typically with the simplest, and that's going to be some basic anti-inflammatory drugs to help keep the inflammation down, to keep the pain down. Exercise, and anytime you tell someone who suffers from arthritis that they should exercise, they kind of look at you funny because it hurts to move. Why are you telling me to move more? What happens with exercise, the muscles become toned and hold the bones in place better. So the bones aren't resting on each other, they're not grinding on each other, the muscles are doing the work. So exercise can be the best thing for someone with any kind of arthritis. Joint replacement, steroid therapy, and biologics. This is a new class of medication. Enbrel, Humira, Orencia, these are all examples of biologics. All of these meds can help suppress the immune system. That's what steroid therapy is going to do. That's what the biologics do in an attempt to minimize the pain and damage that occurs through rheumatoid arthritis. This is an x-ray of someone's hand with rheumatoid arthritis, and if you look at the pinky, the proximal most phalange isn't even close to being in line with the metacarpal. That pain has to be incredible, and that's a photograph of an individual's hands suffering from rheumatoid arthritis. Then we have gouty arthritis. Gouty arthritis is caused by blood levels of uric acid increasing. Uric acid is deposited as urate crystals in soft tissue. So it's, if you've ever had a little pebble or a grain of sand in your shoe, you know how painful that is. Imagine that sharp piece inside of your body. It begins as transient and can become chronic. One of the major causes of gouty arthritis is eating very, very rich food. Organ meat, for example, can be considered this. Drinking alcohol. So the main treatment for someone with gouty arthritis is to avoid alcohol, avoid rich foods, and a medication called colchicine. Colchicine works to remove uric acid from the body. You'll notice if you look at this individual's feet, and I realize they're kind of grody looking, but those white things that you're seeing are in fact crystals of uric acid. This is our last lecture of the skeletal system. We'll start up with the muscular system next.